this. How about now? Can you still see it?
Yep.
Okay, great. And I want this to be as interactive as possible. If people have questions, I can't see any faces, so it always seems like I'm just talking into the void, into myself. So feel free to type it into a chat if there is one,
Oh,
slash unmute yourself and ask questions if that's feasible. How much time do I have for this? Just so I can
uh,
keep track.
roughly 40, 45 minutes.
Okay,
This
all
is a
right.
web format, so there are people who attended, but they can use a Q&A function.
I see. Okay. All right, sounds good. So we're going to go over the management of pituitary adenomas. Brief learning objectives, we'll review the history of pituitary adenomas. I don't know how much of this has already been talked about, but I'll try to go over that portion relatively quickly. I know you've had a couple lectures, including from one last week. And then we'll talk about the differences in management between non-functional and functional adenomas, just in terms of overview of that, essentially. And then understand the role of surgery in these pituitary adenomas, and then some of the risk and patient outcomes, and what the literature shows in terms of how we counsel patients on, do you do the surgery, do you not, and what some of the risks of that are. So we'll start by looking at this case review. This is just so you have a picture in mind as you think about pituitary adenomas. So this is a 53-year-old man who essentially was having vision loss. Hopefully you can see my arrow, but is optic nerve on this side, and then the chiasm in the center. You can see the left optic nerve. The right optic nerve is essentially barely visible there, completely squished by tumor. This does not encase the carotids. Carotids are on either side in terms of the paracel carotid, but essentially it's endocrine labs. This was a non-functional tumor is the bottom line of this. So essentially, in terms of history, in the late 1800s, early 1900s was essentially when this transcranial SELA approach started, but the mortality rate was high for multiple different reasons, including at this time there also wasn't antibiotic. But essentially, the first attempt at treating pituitary tumors transcranially was in the 1893 by Catton and Paul, but they never actually got to the tumor and the patient died during that time. And then in Austria, the first successful transsphenoidal resection was performed in 1906, and then R.V. Cushing kind of took that upon himself thereafter and worked on refining the approach. But even at that time, the mortality rate was high, and for him, it was 5.6%. Which, if we compare that to what it is currently, that's for any surgery, that's pretty high. And then during the time, he wasn't satisfied with basically transsphenoidal approaches, and simultaneously was working on improving his transcranial mortality rate for everything else, and was able to bring that to 4.5. So he kind of shifted back to transcranial approach for these tumors. And the first transcranial approach that Cushing performed was in 1909, and it was for a patient with acromegaly, which I think, this was the patient that the first patient for acromegaly that Cushing had operated on. But so anyway, so then Hirsch, who's an ortholaryngologist, and Hirsch was an otolaryngologist that was also working on perfecting transsphenoidal surgeries at that time. And Cushing also was trying to perfect his approach before he ultimately switched to the transcranial approach. And interestingly, they have worked on the submucosal transseptal approach on the same day. So they're both credited simultaneously for that. Cushing's had many trainees, and as he transitioned to transcranial approach, one of his trainees died. Essentially took that back home to Scotland and continued to use the transcranial approach and perfect that, and also then trained Gerard Gill, who also took that and kind of continued to perfect that. And he's credited for introducing fluoroscopy for guidance, which some neurosurgeons still do to this day in terms of using fluoro. In terms of navigating the way endonasally to the sella. And then this went on to already being trained. A lot of the instrumentation that we use currently are named after Hardy from a transsphenoidal perspective. And then this was how the microscope was introduced. And then subsequent to that, this just shows that people continue to try to perfect access to the sphenoid. Some of it was through the face, which was very disfiguring, and then transitioned to sublabial approach, which was sublabial transseptal. which was done by Hirsch and Cushing's, and then overall, and then subsequent to that, it ended up being endonasal transeptal using the microscope. And again, this is just showing some of those approaches and some of the transcranial approaches as well to the sphenoid and sella region. This is showing the sublabial transeptal approach and the type of anesthesia and that was used back then as well. This is the first endoscope over here. So as we talked about, the endoscope, so it started with the microscope and then the endoscope was introduced. This was the very first endoscope. Bosani, a German physician, is essentially credited with the invention of the first endoscope. And then Bush and Hobbs reported the first use of endoscope in pituitary surgery in 1978. Although Gear is credited with using it for transphenodal approach in particular. And then the endoscope has gone through many improvements over time. Clearly, the endoscopes that we use now is far different from what that was. And then over time with the endoscope application, cellular surgery grew in the mid-90s to where it became pure endoscopic approach and the collaboration between ENT and neurosurgery flourished. This is just some review of the anatomy. This is from Roten, essentially showing some of the midline structures in terms of the septal cartilage, the volar, the rostrum. Again, once you get into the sphenoid sinus, this is parasagittal, looking at the structures in the supraorbital fissure, the paracella carotid, and then basilar over here. Back to this is also parasagittal, looking at the turbinates, just showing kind of the relationship of the superior turbinate and the sphenoid os, essentially. So, we talked about for adenomas, when patient comes in, so that first patient that I'd showed the case study, so I'd show some of the endocrine labs, and the bottom line was, those labs are fine. It's important that all these patients get endocrine labs and endocrine workup, and the first thing you want to know is it a functional adenoma or is it not? And in general, I would kind of tell patients that there's 3 buckets that I classify them into. And the reason I say that is out of the functional adenoma category, prolactinomas, which is a type of functional adenoma, is in its own category to an extent, because it's the one that does well in terms of responding to medical treatment. And as of right now, medical therapy is the first line for treatment of that. And we'll get into some of the nuances of that shortly. But once you send the lab, if it turns out to be a non-functioning adenoma, meaning it's not secreting excess hormone, then you have to look at the rest of the hormone. Is there anything that's low, that's the opposite of excess, right? And that has to be replaced. This is why treating these patients is multidisciplinary. So endocrinology, neurosurgery, ENT, a neuro-ophthalmologist, because these patients can have visual field deficits. And surgery for non-functional adenomas is reserved for documented growth, or if a patient is having clear evidence of vision loss, both subjective and objective, on a formal visual field exam. And in some cases, this is what we call a soft indication. If say there's no growth, you find this incidentally, there's no growth, there's no vision loss in visual field exam, but there is evidence of severe optic pathway compression, right? So then you fall into that gray zone. But I think most of us would offer them surgery because those patients, it's only a matter of time before they develop vision loss and they're at risk for pituitary apoplexy. So from a workup perspective, we talked about the full endocrine panel, the need for formal visual field exam. And it's important to do an MRI pituitary protocol, not just, when this is captured incidentally in an MRI brain, those slices are not thin enough, they're not zoomed in enough on the pituitary gland, and typically they don't have dynamic pituitary sequences in there. So you definitely need an MRI pituitary protocol with and without contrast. And you can actually we have a protocol for without contrast in patients who say are pregnant or they have contrast allergy or for whatever reason. That essentially includes flare sequences and T2 sequences. But these surgeries can be done microscopically or endoscopically. There's been multiple research that has looked at is one better than the other, mostly as it relates to non-functional adenomas, which are really the types of tumors that were included in most of these studies. But in general, after surgery, the average hospital stays anywhere from 1 to 3 days. You have the outliers, right? Probably 1 day is more of an outlier. I think on average, more like 2 to 3 days, to be quite honest. But then you have the other side of the bell curve where people end up being in the hospital for longer for whatever reason. 5 days, maybe they had a persistent CSF leak or diabetes insipidus, and we're not quite sure if it's going to be temporary or permanent. I put this study here because I think it's important. Like I said, there's been many studies that have looked at this, but this one is a good one. It was essentially organized by neurosurgeons for neurosurgeons. And the purpose of this study was to look at the question of, is microscopic better than endoscopic / is there a difference in the outcome of these patients? So it involved 7 pituitary centers. There are particular criteria that you have to meet to be called a pituitary center. That's beyond the scope of this, but 15 surgeons. There was a certain number of cases that the surgeons have to do a year, I think greater than 120 pituitary cases. So it had to be at high level centers. And like I said, most of these, essentially all of them were non-functioning microadenomas. And I point that out because as we kind of come down to the bottom line of this, it's important to know that this is not to be, you can't extrapolate this to functional microadenomas by any means. And this was non-randomized. So essentially those surgeons, some surgeons have preferences, they prefer microscopic, some surgeons have preferences, they prefer endoscopic. More old school surgeons, longer practice, tend to be the ones doing it microscopically. And then the younger guys tend to do it endoscopically. Gross total resection was achieved essentially similar between both groups. The volumetric extent of resection, the length of stay, death, unplanned readmission rates were essentially similar. New hormone deficiency was present at 6 months in 28% of microscopic versus lower in the endoscopic group, that was statistically significant. And the idea being that with the endoscope, the camera is inside the nose, you can easily decipher between gland, what's left of the gland and tumor, and kind of separate that out. Versus with the microscopic, some of it is blinded. The microscopic had significantly shorter duration than the endoscopic. And the reason for that is most of the microscopic cases, ENT is not involved. So it's just one neurosurgeon, all the team in the room is well-versed. There's less equipment that needs to be set up versus with the endoscopic, there's a lot that goes into those cases, and over time being efficient with it, which another reason goes back into these has to be like the criteria for these centers have to be centers that do these routinely. And we talked about the microscopic surgeons were more experienced. And then they essentially supported the transition to endoscopic approach when performed by proficient surgeons, although both microscopic and endoscopic yield overall acceptable surgical outcomes. And this was class 3 evidence. Again, this was not a randomized study. So when we talk about functional adenomas, there's different types of functional adenomas, and essentially they're classified based on the hormone they're secreting. And it's important to, the endocrinologists are very important in these diagnoses for functional adenomas for multiple different reasons. Before they get to us, they undergo extensive workup, right, to rule out ectopic cases of secreting, quote unquote, tumors, to make sure that truly this is a secreting adenoma. Because sometimes, for example, in some Cushing's patients, we'll see some of the algorithm here shortly. In some cases, the MRI is not a slam dunk in terms of the presence of an adenoma, and then you're left with kind of what the ectopic workup show, / do you need to do inferior petrosa sinus sampling to kind of confirm that. But for these functional adenomas, and the reason again I separated the first bullet point from the second major bullet points, because I do tend to put them in different buckets even when I'm talking to patients. Surgery is the first line for the top ones there. Yes, sometimes if say the patient comes in, they're, for whatever reason, so you can't get them to surgery for, 6 weeks. Or logistically, they just don't want to do surgery for 2 months. And sometimes the endocrinologist will start medical treatment because of some of the sequelae, the medical comorbidities that are associated with some of these secreting adenomas. But still, that's with the premise that they're gonna get surgery at some point in the near future. And then for prolactinomas, dopamine agonist is the first line. When I say dopamine agonist, really it's cabergoline. Yes, bromocriptine is an option, but bromocriptine has a higher side effect profile. So it really ends up being cabergoline. And essentially in these situations, surgery is reserved for medication intolerance, lack of tumor response, and persistently elevated prolactin levels. So, like for example, today, I had clinic earlier today, this patient, prolactinoma, who essentially has been on cabergoline. Sometimes I think his prolactin level was in the thousands when he started. And then you see the levels drop. The levels always drop faster than the imaging response. And so now his most recent prolactin level, as of a couple months ago, was 17. And his tumor is now starting to show evidence of shrinkage, and he's tolerating the medication. In some patients, they may have, like, the tumor may respond great, the prolactin levels come down, but they're just like suffering from the medication. They're having severe headache, they're dizzy, right? And I mean, you can't in good conscience leave, those kind of patients on medication for lifelong. So if surgery has any chance of providing them a cure, then in those patients, yes, we would take him to surgery. And it's also important to know that these dopamine agonists, so right now, medication is a first-line treatment, but dopamine agonists, they change the biology of the tumor. They make the tumor more fibrous from a surgery perspective, making it more adherent during surgery. So in and of itself can decrease the rate of gross tumor resection. Although, yes, I mean, it's fibrous, we still end up kind of making it through removing the tumor. But essentially people are starting to look at, doing, and there's a few retrospective studies that have been done, kind of looking at the old question of, do we need to reassess the use of dopamine agonists as first-line treatment for prolactinomas in this day and age? I mean, that algorithm has been there for many years, and in surgery is clear. There's been so many advancements in surgery, just in terms of overall decreased morbidity and mortality from these surgeries. Although it's not 0%, we're clearly better than what it was back then. So, but the ideal question is, which patients if you can find the ideal patient that you can do a low dose dopamine agonist, get rid of the tumor, not need surgery, that's great. Versus an ideal surgical patient where they're young, it's a small tumor, you go in, gross tumor resection, and you save them from needing lifelong dopamine agonists without the morbidity that's involved with surgery, or the, obviously mortality as well. This is where the role of medial cavernous sinus wall resection comes into play for these functional adenomas. And I'm sure Juan probably mentioned that, or at least reviewed some of that with you guys, because it does stand a chance of increasing the chance of achieving remission in these patients, assuming, but sometimes it's difficult if it's a, CNOPS grade 4, where the carotid is completely encased, there's tumor lateral to the carotid, if they already have a complete ophthalmoplegia on that side, then you don't really have to worry about those nerves, but there's clearly risk going lateral to the carotid versus just doing the medial cavernous sinus wall resection. And then radiation is a treatment option, but typically this is a third-line treatment option for functional adenomas, and also for the non-functional adenomas, to be quite honest, just because there's side effects with radiation, depending on how close the tumor is to the optic pathway. The size of the tumor, do they end up getting SRS? Can they safely get SRS, or do they need fractionated radiation? Do they need proton therapy instead? And then bilateral adrenalectomy, BLA, is a third line for persistent Cushing's disease as well. And when we say third line, I mean like they've had surgery and then they recurred, maybe they had another surgery, or maybe for the second line treatment, they, went on medication, but the medication is not providing remission. And then then that's where we're talking about third line treatment. So here, this is just showing, I'm going to move the screen thing so I can see what this slide shows. So this is showing kind of the algorithm that we use. This is a consensus statement / diagnosis that was recently published by our endocrinology group here at OHSU, and multiple other endocrinologists were involved as well. But it's an endocrinology consensus, essentially. So, acromegaly, you see the patient, they look acromegalic, and then you confirm that they don't have a pituitary adenoma as well. and look at the growth hormone. Growth hormone in of itself has a short half-life. So IGF-1, that also has to do with what we check post-op as well, versus IGF-1 half-life, I think it's like 15 hours. But definitely longer than in growth hormone. Growth hormone is also cyclic, and there's so many things that can affect that. So for example, like post-operatively, we check both of them, but we definitely warn patients that it's going to take a while before they notice it, whether or not it's going to completely, they're going to completely go into remission for these acromegaly cases. But essentially they do that. This mentions in some of the associated genetic syndromes that can be associated with pituitary adenomas, and these are some of the clinical features that these patients can have. They can have the gigantism, they can have some of the cardiac sequelae with that. They can have issues with bone issues, like frontal bossing, and then obviously the typical things like their rings increasing, their head increasing, shoe sizes, and things of that sorts. Oh, that's not advancing anymore. Oh, there we go. Let me just make sure that didn't go. Okay. And then, how can I move this down? There we go. So in these patients, so you suspect acromegaly in these patients, so then you look at the lab, you measure the IGF-1 concentration. We talked about kind of why IGF-1 is more important than growth hormone, but typically both of them are checked. If it's normal, then acromegaly is unlikely, then the endocrinologists work them up for other things. In these patients, we don't see them, they don't send them our way. This is why it's crucial to have endocrinology. They can save you some of the headache of this workup. And then if it's mildly elevated, then they start doing some glucose tolerance test to see if it's suppressed, versus if it's not, then they end up getting the pituitary MRI. So this is kind of where we catch them as neurosurgeons, typically in here. Sometimes sometimes we capture them in here, meaning the endocrinologist diagnose acromegaly, and then they order the pituitary MRI and they give us a heads up. Versus sometimes they wait for the result of the MRI, and then once they've confirmed adenoma present, then they send them our way. And then at that point, it's a matter of, are they a surgical candidate in terms of all their other medical comorbidities? Are they safe for surgery? Is the tumor easily accessible and things of that sort? And if it is, then definitely surgery. If the surgery doesn't provide them remission, then they end up needing second-line treatment, which is typically medical treatment. The medical therapy for acromegaly has improved pretty dramatically, to where for the most part for these patients, they can actually cure them with medical treatment after surgery. And then radiation therapy we talked about as a third line. There we go. I know I'm trying to keep track of the time because I do have a couple OR videos embedded in here. I want to leave time for questions, but if I'm going too fast, please just let me know.
Absolutely. This is a great pace so far.
This is not advancing again. Let's see what I do.
Could you try clicking the bottom left of the screen with the right arrow?
Oh, I see. I think I clicked some drawing thing. There we go. And then this is basically showing consensus statement for Cushing. So we were just looked at for acromegaly, and then looking at for Cushing's disease. Again, by the time we get here to this whole question of Cushing's disease, ectopic ACTH secreting tumors have been ruled out, right? That ends the name Cushing's disease, because they've been confirmed to have something that points to the pituitary gland. And then again, in these patients, pituitary surgery is the first line, unless the patient is unstable. Sometimes, like we had a patient who came in, by the time her Cushing's disease was diagnosed, she was pretty bad, like fractures everywhere, pretty frail. And even at that, we try to medically clear her for surgery and things of that sort, and she just didn't do well. So sometimes in those patients, you skip some step and they end up going straight to BLA because they're just not suitable surgical candidates. But if they are, I do pituitary surgery. Ideal scenario, surgery provides them remission, and then they get checked for, or they have to be followed for recurrence. The remission rate, if there's clear evidence of tumor on MRI, depending on where you look, it's somewhere in the 60 to 80% range in a high volume center, right? High volume experience center versus so then and then in terms of recurrence, and again, it's not 100%. So you have to monitor it. It's not 100% remission rate, but even those who undergo remission, they can always recur down the road as well. And the 5-year recurrence rate is somewhere in the 30% range. And then in terms of labs that they've checked, both in terms of originally diagnosing it, typically you need at least 2 labs. So late night salivary cortisol, 24-hour urinary cortisol, and then they do dexamethasone suppression tests. So typically before we get them, all these labs have been done, again, stemming on the importance of having good endocrinologists that can do this. And then when the recurrence is diagnosed, then you go back into looking at the MRI. Is there clear actionable tumor on that MRI? Meaning you can say, yes, there's tumor on the left side over here that if I were to take it out, that increases their chance of achieving remission a second time. Versus if there isn't, you can still take them in if everything points to recurrent Cushing's disease, but with the caveat that you may get in there and not find anything. And sometimes inferior petrosal sinus sampling is helpful in some of these cases. And sometimes some patients would just say, you know what, I just want surgery regardless. I want you to go in and take a look. But doing surgery a second time increases the risk of hypopituitarism, panhypopituitarism in those patients. So then persistent disease, reoperation, again, if there's a good surgical target. If there isn't, medical therapy is also discussed with the patient. Even if there is, you still discuss that with them. And then, weighing the risk versus benefit of surgery and radiation is also discussed. But for the most part, radiation is reserved as a third line treatment, meaning you either do second surgery and medical therapy. If that fails, they go to radiation. Medical therapy, same thing. If say they don't want surgery, second treatment, they decide medical therapy, it doesn't provide control, you can always consider surgery as the third line. And then really BLA is down here, which basically what the BLA does is you're treating the way downstream effect, right? The effect of at the adrenal glands is what you're treating with the BLA. Is the bottom line. But sometimes without the negative feedback loop, some of these, so say they have a pituitary adenoma, they didn't get surgery, they do BLA, without that negative feedback loop, that tumor can increase. So you still have to keep an eye on the tumor. So they're at risk for vision loss if the tumor increases, apoplexy and things like that, which has to be followed over time. So this is just showing, keeping track of time. This is a tumor that we did with medial cavernous sinus. I will mute my apologies. My fellow went wild with the music. Let me see if I can turn that off. And hopefully you guys don't hear that. There we go. So anyways, they do the opening. They take the medial turbinate, taking out the rostrum there, and then getting down to the sphenoid sinus, drilling the sella, taking the bone down, drilling over the carotid on the left side. This particular girl, her tumor was essentially localized to the left side, and then there was also some tumor within the sella. So basically opening all of that up, and then we're starting by taking out the tumor in the sella. First, identifying the gland, identifying the separation of the gland and the tumor. Now we're opening the anterior wall of the cavernous sinus, essentially over the carotid. Her tumor was pretty stuck to the carotid. Actually, she's a prolactinoma, so she had been on cabergoline all her life. She's young. I think she was like in her 30s, and she was just like, I just can't do cabergoline anymore. It was causing like depression and all sorts of stuff, anxiety, and she just had a new kid. So we're pretty aggressive, just trying to get that off of her carotid for her, and even her inferior apophyseal artery was stuck to tumor. But bottom line, we're able to get that out, and ultimately provide her. I'll kind of skip the video here a little bit. Ultimately provide her cure to where she's not. This is peeling the tumor off of the carotid. You can see how adherent it is. So carotid is right here, and peeling that off. And this is at the top, just disconnecting it from the diaphragma sella. And then ultimately getting that out, separating it from the pituitary gland right there, and then just the last finishing touches, and then getting that out into enough pathology. So it was confirmed in pathology that was a tumor. This is just inspecting the rest of the sella. And her prolactin level came down, normalized without her needing any dopamine agonist. So hopefully that provides her, long-term cure. And then, let me see, go to the next one. And then this is an acromegaly case, and this one didn't take the medial wall down. Like I said, the medical treatment for acromegaly has gone up dramatically, and this wasn't involved in the cavernous sinus. So similar approach from an endoscopy perspective, exposure, separating during a rescue nasal septal flap. And just kind of showing what that looks like just when we're in the sella. That's tumor coming out there. Some of it is necrotic tumor. You can see that peel off. You're just showing the differences in the texture of the tumor versus that other girl that her tumor post-cabergoline was all just like a Darren tumor, right? Like it didn't just like fall out like that in there. So that's what I mean in terms of the change in the biology of the tumor with dopamine agonist versus not. This person had a little bit of a CSF leak there. And now just inspecting the medial wall there, just making sure there's no tumor hidden. That's the gland, the manipulating to kind of take a look, inspect that side of the wall, and then we'll inspect the other side as well too. And then once we're done, we get hemostasis, and then we kind of seal that up. That's the nasal septal flap because we have the CSF leak. So now let's take a look at complications. Looking at time. So complications for both of these, a lot of complications can happen. CSF leak, sometimes with these, it's more of an expectation, not a complication. Like if the tumor is a macroadenoma already violating diaphragmatic sella, like that first case that I started with, and that one for sure, he had a CSF leak, and that's expected. Patients can have transient or permanent DI, SIDH, pan-hypopit, vascular injury. You can see dissecting that medial wall there. It's not to be taken lightly. There's a risk of carotid injury with that. There's a risk of pseudoaneurysms. Patients can have vasospasm as well too, and post-op hematoma as well too, to where you have to take them back for surgery. Just showing some of the data on some of these complications. Essentially, the bottom line with this is the nasal septal flap revolutionized the CSF leak, persistent CSF leak rate to where it was less than 5%. So we actually have a protocol that we use in terms of deciphering who ends up getting the nasal septal flap, because that also has some morbidity that's associated with it, versus who ends up getting just a free graft or Duragen or something like that, standalone matrices. And then in terms of diabetes insipidus, overall risk of diabetes insipidus is anywhere up to 30%. Rathke's and craniopharyngiomas, for obvious reasons, they involve this stalk, are more likely to have diabetes insipidus. But the bottom line is for just pituitary adenomas, risk of permanent DI is low. Depending on where you look, it's 2 to 4% essentially. And so these patients, that's one of the things we watch for while in the hospital, trying to determine if they end up needing to go home on desmopressin or not. And then hyponatremia is one of the most common cause of hospital bounce back in these pituitary patients. Vascular injury, as we talked about, it can occur. The risk is about 2%, less than 2% or less is the risk. And the bottom line is there's papers that look at, what do we do in the setting of vascular injury? Bottom line is there are things that we can do, including all the endovascular stuff that you guys are probably privy to already in terms of coil, embolization, sacrificing the vessel, and things of that sort, which is kind of what this shows here. And the preferred method, unfortunately, when there's a vascular injury, it really ends up being ICA sacrifice, is what ends up happening in patients. Some of the delayed complications, so epistasis can happen. Patients can have pseudoaneurysms. So when you do that cavernous wall dissection, all these patients get CTA pre-op. It's important for multiple reasons in terms of analyzing the bony anatomy, the vascular anatomy, but then also for establishing baseline what the carotid looks like. Vasospasm can occur. When it occurs, it can be pretty bad. I've had one patient that came in with severe vasospasm, unexpected. She was doing great, left, and then like post-op day 7, bounced back, had a really poor course after that. But it's definitely reported, and like I said, I've experienced it. And then delayed hyponatremia, it's the common reason for bounce back. This is another place where endocrinologists are crucial. Our endocrinologists get, all our patients get post-op day 3. When they leave the hospital 3 days after leaving the hospital, they get sodium checks, essentially sent to the endocrinologist just to so we can capture them before they bounce back to the hospital. And then some patients could get hydrocephalus, and then hypopituitarism and sinus complications as well. Vasospasm, we kind of talked about that. Hyponatremia, we talked about that. The incidence is similar with microscopic and endoscopic. Visual recovery. So, you see these patients, they ask you, well, doc, like, is my vision gonna get better? I mean, I have bilateral visual field loss. That's more common in non-functional adenomas, because a lot of times when these non-functional adenomas present, the tumor is already fairly large, right? Because they don't have any symptoms. They're not like having galactorrhea or, acromegaly features or anything like that. But these tumors, they can affect not only visual acuity, they can affect the visual field, which we all know about, and then color vision as well. And there have been multiple studies that have essentially looked at, like what's most important in terms of visual field recovery. And the bottom line is age, preoperative visual acuity, the mean deviation from normal, presence of bilateral visual field defect, central visual field defect, all influence the likelihood of visual recovery. And then tumor volume as a factor has been found to be positive in some studies, but it probably has to play a role in, if tumor is pretty large, you're likely going to have issues with all these things that we talked about here. And then vision continues to improve until about 3 months after surgery. This is why, like, when they do that baseline visual field, most ophthalmologists or optometrists, they're not going to want to do another one until at least 3 months post-op, because there's no point in like checking until then. And then people said basically the bottom line with this is they've basically talked about like how thin the nerve fiber, like when you look at the scans, if the nerve is like super thin and stretched out, then that has a poor influence on visual recovery. Basically, if you've lost neurons, you're likely not going to get it back if they're thinned out, is the bottom line of that. And to kind of conclude and leave some time, we're just about 15 minutes into how much time we have left. The treatment of pituitary adenomas, it's multimodal. Hopefully I've kind of shown that and emphasized that in all of what I've said. And the management should be at a pituitary center where there's good collaboration between endocrinology, neurosurgery, and ENT, and there's good team staff support, and where everybody's well versed on these cases. Endonasal approach, although it's the preferred approach for these tumors, it may not be ideal in some patients. So it's important to kind of take a look at the scan, talk about the CTA. Some patients can have kissing carotids, where the intercarotid distance is essentially pretty narrow, right? And you can't safely work in there. Or some patients can have sphenoid sinuses that are not fully formed. And so you can't really get in there, or it's partially formed and you just have to do a lot of drilling. Doing a lot of drilling is not the end of the world, but you just have to be cognizant of that as you plan for these cases. And then always giant adenomas, which, giant adenomas basically may require a combined stage approach, right? Meaning you may have to do some transcranial, some transsphenoidal, and then choosing which one goes first is still left to debate. I mean, we published kind of our series on that, and the bottom line is it really just depends. So sometimes some people feel strongly about doing transcranial first. I think my preference is always to go endonasal first, because sometimes you'd be surprised how much you can get out through the nose, and maybe you don't end up needing to do a transcranial portion because the tumor descends down, and then you're just left with the stuff by the lateral cavernous sinus, which you're not really going to chase too much if they don't have a ophthalmoplegia from the top. So but the bottom line is being aware that sometimes you need to stage the approach and require both, but it's really on a case-by-case basis.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.